I work as an emergency physician at the Semmelweis University, at the emergency department. My vision is that visiting the emergency departments helps to improve not just the actual problem of the patient, but their global health and long-term health of them. And for that, my mission is to improve the care of patients in the emergency department and beyond by doing good quality research about the treatment and the management options as well. I have 3 ongoing projects at the moment. The first one is a meta-analysis about 2 score systems about patients with chest pain visiting the emergency department. We know that every year more than 5 million ED visits happen in the United States with chest pain, and the majority of these people are discharged because they don't have any major issues. But they do put a large burden on the emergency departments. So there are a lot of score systems developed which can improve the velocity of the treatment and also doing it safely. A recent consensus statement came out in the US which recommends 2 of those score systems to be used, but they don't really say why they think that, and they leave the question open whether or not you have to use it or you should use it or just you can use it if you want. So there is no really strong evidence in that regard. So our aim is to find out if the use of those 2 score systems are better than usual care, and if one is happened to be best, then we could say that we recommend that over than the other one. So the question is the use of the heart score or the EDACS score superior to the standard of care? Hypothesize that the heart score is more accurate in risk stratification. There are a lot more data about heart score than EDACS, and it shows a signal, but we have to investigate it a bit deeper. So we did systematic research with that search key you can see here. It resulted in a lot of articles. I excluded all the articles before 2008 because in 2008 was the publication date of the heart score, so no prior data happened to that, but it was still a large number. Right now we are at 803 articles to be reviewed, and it's still in progress. My second project is developing the Hungarian Major Trauma Registry. There are more than 150,000 people die in the EU because of trauma. And we also know that having trauma registries are the core at the management, because we can answer questions, we can see how we perform and how we can improve. But unfortunately in Hungary we don't have any available data about the treatment of major trauma patients. So our aim is to establish a registry which can collect data in that regard. We had a network meeting 2 days ago. This was the first network meeting with good and knowledgeable people, and we agreed in the timeline and our focuses and the next steps. So in the following weeks we have to do background search, we have to find out what other nations do in terms of trauma registries, and so we can build up our own. And my third project is my field of interest. It's coming from my field of interest of geriatrics. There are a lot of elderly visiting the emergency department. Actually, their proportion is overrepresented in the emergency departments. And because there is an increasing numbers and proportion of the elderly in the population, which is projected to be around 27% within 10 years in the EU, it will mean a lot of work for us emergency physicians. We know that there is an European mission statement about emergency care and how it should treat geriatric patients. And we also know that 20% of the geriatric patients are returning to the emergency departments within 30 days. And that's a population that probably should be at home or should be in a place where it's much safer for them than the emergency departments. And there is a chance that we missed something at the first visit. So we have to dig a bit deeper into that field to see if we are doing something good or bad there. How can we reduce that number? So I want to find out the risk factors associated with these unplanned return to the emergency department. And for that, I did a preliminary research which states that there is a growing interest. The numbers each year are elevating, but scarce or no available data is coming from Central and Eastern Europe. So I started to work on that with Miklós Tóth, who is the head of the geriatric department of Semmelweis University, and we agreed in some key points that we need to investigate a bit further. And I also started to collect our own data at the emergency department retrospectively to see first the quality, and second, if we can answer that question at all based on those data. So just to summarize, these are my ongoing projects, and thank you for your attention.
Thank you, Szabolcs. I would like to have a question for your third project.
Yes.
What kind of risk factors are you planning to investigate? Are these medical risk factors regarding the past medical history of the patients, or are you also going to include social factors as well?
It's an excellent question. So retrospectively, unfortunately, we cannot go for the social background because it's just not there. The data is not there. So first, we need to investigate the medical risk factors. But this is just the first step of an ongoing line of projects. So based on that data, we plan to put together a prospective investigation just to see which are the factors, medical, social, or other factors that are influencing our patients' return to the emergency department.
I have a question about the population in the geriatrics appearing on the emergency department. What is your experience? What is the percentage of those geriatric patients appearing because of the end-of-life care somehow? So I can imagine that it's a big population among the elderly who is, because of social structure of our society, appears there because of deteriorating illnesses more and more, and it's sort of an end-of-life care in the last months or years.
So just by definition, end-of-life care means that we expect that patient to decease within a pretty short period of time, so 24 hours. That number is not that high, so only a few percentage of these elderly people are there because of that. But certainly in the past few years, we've seen an elevation of those who came in because of that. If you refer to the hospice care, which is basically just an untreatable disease, and they are there because of its deterioration, also the numbers are getting higher and higher. I can tell you data from last year. I think the third of our patient population was over 55 years old, and so maybe I'm not exactly sure about the exact data, how much of those because of end-life decisions, but my gestalt is that the numbers are elevating, but it's still not the majority of the elderly who are there because of that.
I just have a question about your second project. That what are the questions that you would like to answer with this trauma registry?
That was the question of the meeting of Monday as well. So where do we put our focus? For sure, what we want to include is the coagulation management and blood product management of trauma patients. So that's going to be one goal, to investigate how we manage major bleedings and what are the factors that influence the care of the Hungarian major trauma patients in that regard.
I'm just curious that in your first project, you said that actually there are different, I mean, there are the standard kind of evaluation and there are the two scores. So are there studies which actually compare the two scores? Or you are the one actually compare that too?
Yes, there are a few studies out there, but their number is just not enough to do sole research on those two.
Good luck with this.
Thank you.